All right, welcome to The Explainer. Today, we're jumping right into the essential guidelines for managing tuberculosis, giving you a clear, practical framework you can use in your primary care practice.
So, where are we getting all this from? Well, everything we're talking about today comes straight from the source, the authoritative 4th edition of the Clinical Practice Guidelines on the Management of Tuberculosis. This is basically our evidence-based playbook. And to really get a sense of why this matters so much, just look at this number, 1.7 billion. That's not million, it's billion. We're talking about nearly a quarter of the entire world's population living with a latent TB infection. It's a massive, staggering figure, and it really shows the scale of the challenge that you're facing on the front lines.
So, here's how we're going to break it all down for you. First, we'll do a quick guide to TB. Then, we'll dive into the crucial difference between active and latent TB. After that, we'll walk through how to manage both of them, and we'll finish up with your key, non-negotiable responsibilities.
Okay, first up, let's lay down the groundwork. What's your role as a primary care doc in the modern TB challenge? Now, this is probably the most important distinction you're going to make. Are you dealing with active TB or is it latent? Getting this right from the get-go is absolutely crucial because it changes everything. So active TB, you can think of this as the bacteria being awake and on the attack. They're multiplying, they're causing damage, and they're making your patient sick. You're going to see those classic red flag symptoms: the cough that won't go away, the fever, the night sweats, the weight loss that you just can't explain.
And then you have the complete opposite, latent TB, or LTBI. Here, the bacteria are basically asleep. The body's immune system has them locked down, so your patient feels totally fine, no symptoms at all, and, this is key, they can't pass it on to anyone.
This slide just lays it all out so perfectly, right? On one side, active TB. Your patient feels sick, they can infect others, you'll probably see it on a chest x-ray, and you've got to hit it hard with multiple drugs. But on the other side, latent TB, asymptomatic, not infectious, and the goal here isn't treatment of disease, it's prevention. All right, so let's get practical. How do you actually manage active TB? The good news is you don't have to guess. There's a really clear pathway to follow. And here it is. Think of this algorithm as your roadmap. It all kicks off when a patient shows up with symptoms. Your first big question is, are we looking at TB in the lungs? That's pulmonary TB. Or is it somewhere else in the body, which we call extrapulmonary TB? So if you're suspecting it's in the lungs, your workup is pretty focused. You're going to need sputum samples, and you'll send those for AFB, culture, and definitely a rapid test like Expert Ultra. And of course, you'll get a chest x-ray to actually see what's going on in there.
And once you've got that confirmation of drug-susceptible TB, this is your game plan for treatment. It's the standard 6-month daily regimen. It's broken into 2 parts, a 2-month intensive phase with 4 drugs, then you dial it back to a 4-month continuation phase with just 2.
Okay, let's switch gears completely. What about latent TB? Remember that huge number, 1.7 billion? This part is all about prevention, making sure those people never get sick with active disease.
So who should you be screening? Obviously, you can't test everybody. The guidelines point us straight to the highest risk groups. We're talking about household contacts of active cases, people living with HIV, and basically any patient whose immune system is compromised for any reason.
And the process itself? Super straightforward. Just 3 steps. 1, and you cannot skip this, you have to make sure they don't have active TB. That's first. 2, you test them for the latent infection, using either an IgRA blood test or a TST skin test. And 3, if it's positive, you treat. Simple as that.
Now, this is a really important update. We've moved away from those really long, old-school treatment plans for LTBI. The guidelines today strongly push for shorter regimens based on rifamycin. Why? Because they work just as well, and patients are way more likely to actually finish them, which is a huge win. Okay, let's wrap this up by talking about your key responsibilities. These aren't just suggestions. These are the non-negotiables for every single clinician who manages TB.
And number 1 is notification. I can't stress this enough. This is a legal requirement. Every single case of active TB has to be reported to your public health office within 7 days. No exceptions. This is how we find contacts and stop the spread.
Your second big job is making sure your patient actually finishes their treatment. The gold standard here is something called directly observed treatment, or DOT. This means a healthcare worker actually helps the patient take their pills. It sounds intense, but it's the best way we have to ensure they get cured and to prevent scary drug-resistant strains from developing.
So what's your role in ending TB? Well, it's all right here. It's about making that crucial distinction between active and latent disease, following the right treatment plan, and doing your public health duty by notifying and ensuring treatment gets completed. You really are on the front lines of this fight. The only question left is, what are you going to do with this information tomorrow in your clinic?